But good evening. Thank you for coming. Today's presentation for OCDRI is on taboo thoughts, common presentations, as well as treatment approaches. So my name is Maria Mancebo. I am a clinical psychologist at Butler Hospital. I'm also the program manager of the OCD and that's my background noise, so sorry about that. There's nothing I can do about the sound, but I will try to mute that a little bit. So I'm a clinical psychologist at Butler Hospital and the program manager of the OCD and Anxiety Disorders Intensive Outpatient Program. I'm also an assistant professor at the Alpert Medical School of Brown University, where I teach psychiatry and psychology residents on behavioral therapy, how to use behavioral therapy to treat OCD and anxiety disorders. So tonight I'm going to talk about a subtype of OCD called taboo thoughts. There's different names that you might hear for this subtype of OCD. Taboo thoughts, unacceptable thoughts, forbidden thoughts, harm OCD. There's different references to this particular type of OCD. And I'm going to describe some very common presentations of what OCD might look like. And we're going to talk about why some people develop this particular type of OCD and which treatments work best. So let's start with some common presentations. So aggressive or harm obsessions are fears that someone is going to act on an impulse or lose control. These can include thoughts or images of harming a loved one, an innocent or helpless person. So if you can imagine someone who has a newborn that they love and have normal anxiety about taking care of, and then suddenly they may have an intrusive thought. What if I intentionally did something to harm this very vulnerable little baby? What if I intentionally dropped this baby? That would be awful. What if I, somebody's standing by the train tracks or the subway and they have this random intrusive thought? What if I push this elderly person that's standing there onto the train track as the train is coming down? Or what if I drove my car off of this bridge as they're driving across the bridge? Or maybe they're making dinner and they're chopping up some vegetables and they look over and they think, what if I stabbed my husband with this knife right now? Those are some examples of what we call aggressive or harm obsessions. They can also be about oneself, so the thought that I might lose control and harm myself, either by reaching over and drinking something that's poisonous or committing suicide. And again, it's not that the person is having these thoughts and thinking that they may want to do this. It's more of a fear that they'll act on some impulse and lose control and that this terrible thing will happen. The themes can also be sexual. So if someone is straight, they may have the intrusive thought that, what if I'm not straight? What if I'm gay or bisexual? Or the reverse, if someone is gay or bisexual and they have intrusive thoughts that they're straight and they're misleading their partner or living a lie, or some terrible consequence of that. What if I'm a pedophile? What if I inappropriately touch my child? And they don't necessarily need to be thoughts. People experience these as images that just pop into one's head. And these intrusive thoughts are marked by persistent doubting, and that's the hallmark of OCD in all of the subtypes, is that the person gets stuck in this loop of doubt. So what if? And they have trouble coming out of this loop. The images and thoughts are not experienced as pleasurable, but over time, people feel driven to test whether or not, or to check and confirm that this is not the fact. So if they're wondering if they're a pedophile, they may engage in some checking behaviors because they just want to be sure. It's very difficult to tolerate the doubts and the uncertainty that come with these obsessions. And so people will often resort to checking rituals. Another category of taboo or unacceptable thoughts have religious themes. Did I have an impure thought when I said that prayer? What if I blurted out a blasphemous phrase in church? Did I offend God? Morality obsessions, for example. When I went into CVS this morning, did I cheat the cashier by giving him less money? Did I give someone the wrong information? When I was coming in this morning and I walked into the lobby and that person asked me where the emergency room was, and I pointed down the hall, did I give them the wrong information and cause them to go to the wrong department and have something terrible happen as a consequence of what I just did? So, in addition to the obsessions, people with OCD also have rituals. And they don't need to have rituals, but most people do have rituals. And they're either overt behaviors that the person will engage in to cope with the intrusive thoughts, or they can be mental rituals. You might have heard of pure O, OCD, where that refers to pure obsessions with no ritual. That's actually quite rare. We have learned that most people have some rituals. They may be mental rituals, things that they do in their head when they have these intrusive thoughts. Mental rituals, for example, if someone has a bad thought or an impure thought, they may feel compelled to neutralize it with a good or safe thought. If they have an image that they find intolerable, they may try to neutralize that by trying to picture something that feels safer. Ritualized prayers are also very common rituals. Asking other people for reassurance is also very common. For example, asking a loved one, do you think I would ever do that? Or do you think that when I walked by you, did I hurt you just now? Or did I do something to offend you? Those are some examples of asking other people for reassurance. Checking that what you're afraid of did not happen. So if you have a thought that you might have hurt someone, checking and calling that person and making sure they're okay is an example checking to disprove the thought. So, for example, with sexual obsessions, checking your body to make sure either that you are aroused when you look at certain photos, or you're not aroused when you look at other photos. And that can lead to this endless loop of checking. Checking facts on the internet, especially, do I have harm OCD, or do I have a sexual obsession, versus am I a pedophile, or am I psychotic, or someone who would actually hurt my loved one. Those are examples of rituals that people may initially have good intentions. They feel like they may try to get more information to be able to have some certainty that they're not going to harm anyone. But what we know about OCD is that the more that you engage in these rituals, the more compelled you are to keep going, and you need more and more rituals when you're feeling anxious. Checking that harm is not imminent. For example, making sure that the knives in your home are in a safe place, or getting rid of them altogether, is an example that's pretty common. Avoiding preparing certain foods. So if you have a fear that you may accidentally poison someone, then that might lead you to not put yourself in those situations. So you avoid cooking or preparing food for loved ones. If you're afraid that you're going to harm your child, you may start to avoid being alone with your child. And if you are very anxious about whether or not you're a certain sexual orientation, you may avoid contact with certain people, or avoid certain places because of these obsessions. So I'm going to give you an example of a woman that I treated years ago. All of the identifying information has been changed. So her name is not really Michelle, and she was not really 25. But she was a young woman with a 3-month-old daughter. And she experienced a sudden onset of harm obsessions. She had had some OCD prior to having this baby, but it was always mild, never got in the way of anything, and never taboo thoughts. She had some hand washing contamination obsessions, which didn't really cause a huge problem for her, and she never got any treatment for that. But after the birth of her daughter, she was bathing her daughter, and all of a sudden had these thoughts that she might hurt her daughter. And they startled her. And then they happened again when she was putting her to bed. And so she was so scared, she started to engage in these rituals and ask her mother and her partner for reassurance. And confessed her thoughts, and asked them if they thought that she could actually do this. Why was she having these thoughts? And then her symptoms just spiraled, so that they were very time-consuming, present most of the day. She spent a lot of time actually trying to review evidence that this can't possibly be true. I would never be a person who would harm their child because this, and this. But it was her way of trying to push out these obsessions, and she just became consumed by these thoughts. She also started to avoid a lot of her caregiving responsibilities. Her mom or her partner would put the daughter to sleep, She was petrified of being alone with her daughter, so someone was always home when she was caring for her daughter. She also would avoid pillows or sharp objects or anything that could harm her child. She couldn't have those things in the same room with her and her baby. And certain TV shows at the time, it was Law and Order, SVU, anything that had these kinds of themes of hurting children, she absolutely had to turn off, would not watch the news, wouldn't watch these shows. She had what we would call good insight. If you asked her, what's the probability that this is true, that you would hurt your daughter? And she would flat out tell you, I know I would never hurt her, but I need to be 100% sure that my daughter will be safe. So when I have these thoughts, I can't be sure. But when the anxiety came down and she was sitting in my office, she could tell me that she was 100% sure that she wouldn't hurt her, but what if that wasn't true? And what if that changed because she didn't feel the same way when she was in the presence of her daughter. She was scared to death then, and she didn't know whether, if you asked her the same question, she wouldn't be able to answer that whether or not she would hurt her daughter, which was a very scary thing for her. So we'll get back to Michelle. I'll give you some examples of what we did in her treatment. But a little bit of background information about taboo thoughts. Back in 1992, Doctors Rasmussen and Eisen from Butler Hospital and Brown University published a study of 560 patients that they had treated in the OCD clinic here at Butler Hospital. 1/3 of them had reported taboo thoughts. Later on, in 2006, we had a grant from the National Institute of Health where we recruited and followed 293 adults whose primary psychiatric illness was OCD. 45% of them reported that they had taboo obsessions. And we know that patients are much more reluctant to share these thoughts with clinicians and researchers, so that we actually think that these rates are likely an underestimate of how prevalent taboo thoughts are. So what causes someone to have this kind of OCD? So first of all, we know that taboo thoughts are universal. These kinds of thoughts, these examples that I listed, are normal. We call them normal intrusive thoughts because there's been several studies to show that if you give this list of intrusive thoughts to people with OCD and people who have no diagnosable condition, there is no difference. You can't tell people apart. Everyone has some of these thoughts at some point. And this is just a list of some of these studies. And we know that normal thoughts develop into obsessions when they give rise to negative automatic thoughts. So it's not the intrusive thought that is what causes the anxiety. It's that the person with OCD is more likely to interpret having that thought as something dangerous, unnatural, or harmful, whereas somebody without OCD may just dismiss that thought, and it doesn't get stuck in their mind. And someone with OCD is also more likely to believe that they must do something to prevent a feared outcome from happening when they have this intrusive thought. And there's also a lot of research to support that thought suppression, which means trying to push out thoughts actually has the opposite effect. The more you try to push thoughts out when you have them because you don't want to have them, the more frequent they will become. And if you know something about OCD, you know that you don't choose to have OCD. It's a neurobiological disorder. It has a genetic component. It runs in families. About 25% of people with OCD have a first-degree relative that has OCD. Twin studies indicate that genetics contribute about 45 to 65% risk. And neuroimaging studies have taught us that brain functioning looks different for people with active OCD symptoms versus without. And there are certain areas of the brain that function differently. And there are circuits of the brain that react differently. So, for example, a false alarm, when someone has an intrusive thought, a false alarm is more likely to go off in someone who has OCD versus someone who doesn't have OCD. And certain thoughts are more likely to get stuck in your brain. And you can imagine then how scary it is to have a thought that is frightening get stuck in your brain, and you start to ask yourself, like, why is this happening? That can be a very scary experience. Behavioral conditioning also maintains, so people may develop OCD symptoms and they're maintained over time through what we call behavioral conditioning. Compulsions or rituals are these learned responses that reduce distress. And rituals are negatively reinforced, and I'm going to explain what that means with a picture in a little bit. But when someone performs a ritual, there is an immediate reduction in anxiety. They do feel some relief, but it's temporary. And rituals and avoidance over time become excessive and very time-consuming. Cognitive scientists have also done a lot of research to support that there are common misinterpretations that maintain OCD symptoms. People may often worry that they may act on the thoughts. Bad things are more likely to happen to people who have these thoughts. I should be able to control the kinds of thoughts I have. Those are all beliefs that people with OCD might have that cause them to have more fear or anxiety when they experience these intrusive thoughts. There's also some data to show that people with taboo thoughts have a heightened attention and control. They're more aware and pay more attention to these thoughts. So thinking back to that example where lots of people may have an intrusive thought about harming a newborn, they may not even be aware that they have that thought, and they may not pay attention to that thought. People with this subtype also tend to put more effort into trying to control their thoughts. So now I'm going to go into treatment approaches for taboo thoughts. And you may or may not be surprised to know that we treat taboo thoughts just like we treat other types of OCD. So the American Psychiatric Association practice guidelines really are very clear that the first line treatment for someone who has OCD, regardless of subtype, is either an antidepressant or cognitive behavioral therapy, and exposure and response prevention specifically are the first line treatment approaches. And most people do need a combination of both an SSRI and exposure and response prevention, but there are many people who do well just with one of these treatments. Clinical trials support that exposure and response prevention, either with or without medication, is the most effective and has the most long-lasting results. 65 to 80% of individuals who complete exposure and response prevention treatment improve significantly at the end of treatment. And ERP, which is short for exposure and response prevention, works just as well for taboo thoughts as it does for other subtypes, if you do it correctly. Now, that is one of the things that sometimes you do need to see someone who has experience with exposure and response prevention for OCD to identify a lot of the subtle avoidance behaviors or the mental rituals, because that's one of the most common reasons why I think that I've worked with some people and they've worked with a therapist in the past and they say they've done exposure and response prevention, but there wasn't much attention paid to the mental rituals or the avoidance, the subtle avoidance behaviors, and that might have been why treatment didn't work. Cognitive therapy is also effective if you use something called behavioral experiments. So if you come in for treatment for OCD, what happens? You do go through what's called a diagnostic assessment by a mental health professional. So we need to be clear that someone has OCD, and we need to rule out whether they are really suicidal or homicidal, or whether these sexual thoughts are paraphilias, or whether they have something called psychosis. And I'm not going to go into how we do that. I would just say that it's very common that people doubt whether or not we're diagnosing them correctly. And I can only tell you that when someone has OCD, it is very clear to me that it is OCD. And when someone has these other psychiatric conditions, it may not always be apparent to the person, but we can, if you're seeing someone who has experience in treating psychiatric illnesses, they will be able to diagnose the OCD. We start with, when we're doing cognitive behavioral therapy, we start with some education about what it is, what are normal intrusive thoughts, why this treatment works, what it's going to look like. And then we ask people to self-monitor their symptoms. Then we usually start with some exposure and response prevention and some cognitive restructuring. If there is family accommodation, so if there are family members that are doing a lot of rituals for the person with OCD, or They may be doing a lot of the caretaking so that the person with OCD does not can avoid situations that make them uncomfortable. Then we do work with the family as well and help the family increase support for their loved one without reinforcing the OCD. So this is what I mean by the behavioral therapy model and how treatment works. So you start with a normal intrusive thought. And in Michelle's case, it's, what if I suffocated my daughter with this pillow? And here's the pillow right by her crib. I could just reach over and suffocate her. And then the misinterpretation was that, oh my gosh, why did I have that thought? There must be something wrong with me. I must be a bad person. And so that caused a lot of fear and anxiety and doubt. And that's when she started engaging in rituals and avoiding, no pillows in the room. And every time she did that, every time she either got rid of the pillows or asked for reassurance, she felt a little bit better. And so that just fed the belief that when she has these intrusive thoughts, there must be something wrong with her and her daughter may not be safe. So what we do in exposure and response prevention is we try to break that cycle by having her cope with these intrusive thoughts without rituals or avoidance behaviors. And when you do exposure and response prevention or exposure and ritual prevention, we can use either term, clients learn to confront their fears. And they do this either by just sitting with the thoughts and tolerating it. And that might be writing it down, saying it out loud, listening to it, imagining it. They may just sit with an image and record a detailed description of this image that they're afraid of. Or they may intentionally go into situations that they're afraid of. So, for example, in Michelle's case, just being able to hold her daughter, sit in her chair, and have the pillow right there within arm's reach. That was an example of how we tried to reduce avoidance behaviors. And but at the same time that you're doing exposure, you need to also be refraining from doing rituals, because you need both exposure and ritual prevention in order for it to be effective. So the goal of this treatment is really to help the client learn to be less fearful of their own thoughts, and to learn that thoughts themselves are not dangerous or threatening, and to learn that distress is tolerable and that they can tolerate it, and that it doesn't stay, they don't stay distressed for forever. The goal is not to desensitize individuals to the idea of harming loved ones. And that is one of the reasons why people are reluctant to do this kind of treatment, is they are afraid that they might act on an impulse, and if they're not anxious about this, then they're more likely to do the thing that they're afraid of. So we try to do a lot of education to help people understand that that is not, this kind of treatment doesn't turn you into a serial killer or a pedophile or anything like that. That is not the goal of the treatment. Exposures are done gradually, so we can come up with a list of different things, different exercises, and the person learns to rate their distress on a scale of 0 to 10. And they start with moderately distressing exercises and work their way up to more challenging ones. You do need complete ritual prevention, so you know, doing some checking and asking for reassurance is not going to be helpful. It may actually interfere with the effects of the treatment. You need to do exposures repeatedly, and you need to do them long enough for the person to experience corrective learning. Sometimes you need to do them long enough for the distress to come down, but you don't need to have the distress come down in every session. You just need enough time for the person to learn that, hey, this is not a dangerous situation. And so let me give you an example of what a hierarchy looks like. So for Michelle, she was scared to death of holding her own daughter when she had these thoughts. So we created a tape, and this is very difficult to do, but she created a recording of her thoughts, of thoughts of stabbing her daughter, and she started to listen to those thoughts while holding her daughter. And at first, she brought her daughter into my office and did not hold her daughter, but just had her close by in my office. And so that was, on a scale of 0 to 100, that was about a 50 for her. And she was able to do that a few times. And then we gradually moved up. So with someone else in the room, standing by the door in the same room, and then being alone with her daughter, but having someone else in the next room. So not in the same room, and so they couldn't see her, but they were close by. And she worked up to being able to listen to these intrusive thoughts, hold her daughter when no one was home. She was able to use a knife to prepare a meal with her daughter in the next room, and then moved up to being able to use a knife to prepare a meal with her daughter in the same room. And then the final exercise was being able to hold a knife while having a thought of hurting her daughter with her daughter in the same room, and no one else at home. Cognitive techniques also are helpful, and so these techniques, so the response rates for cognitive therapy are about 60 to 80%. Although there are fewer randomized controlled trials for cognitive therapy than there are for exposure and response prevention. So what we do with cognitive therapy is we try to work on common OCD beliefs. And we try to help people identify distorted thinking. So when we're anxious, our thinking becomes distorted, and we start to make mistakes in how we perceive things. So overimportance of thoughts. An example would be that thinking about stabbing someone is just as bad as doing it. If I have this thought, it must mean that deep down I'm really a monster. Control of thoughts. Only bad people have these types of thoughts. If I wasn't a bad person, I wouldn't have these intrusive thoughts. And I should be able to control the content of my thoughts. Those are common misperceptions of OCD. Overestimating danger. So if I have this intrusive thought while holding her, I might actually do it. A desire for certainty is also very common. I must be certain that this will never happen. consequences of anxiety or loss of anxiety. So if I get really anxious, I'll go crazy and lose control. Or if I don't feel anxious, then I might actually do it. And fear of positive experiences. I won't be able to enjoy myself because I'll get these horrific images. So in cognitive therapy, we try to do something called cognitive restructuring. And the goal is to construct a new, less threatening explanation of the patient's experience. So we start by learning how to identify distorted thinking. For example, overestimating the likelihood of threat. And then we replace with more accurate thoughts. For example, there is a low likelihood that the feared outcome will occur. And placing an importance on the meaning of thoughts. Whenever you have a thought, you have to figure out what it means. And an intolerance of uncertainty. We also help people gather evidence for and against the truth of obsessions. But that can become a ritual in itself, and it's not something that we frequently use for this type of OCD. Behavioral experiments are, in my opinion, necessary for cognitive therapy to be effective. And what behavioral experiments are, they're really exposures where you test out hypotheses. So how likely is it that you will get so anxious that you will lose control and do something terrible? And we plan out an experiment to see whether or not that's true. So in summary, taboo thoughts are just as likely to respond to cognitive behavior therapy as other types of OCD. The stigma associated with the content of the thoughts really creates additional barriers for people getting the proper treatment because they're reluctant to share these thoughts. There are some resources. The International OCD Foundation website has a lot of information and videos and lunch and learn talks, and they often cover taboo thoughts. They have some patient testimonials from people who suffer from taboo thoughts and have gotten treatment. There's also another website, intrusivethoughts.org, that has a lot of information on taboo thoughts. And there are some books that I've listed here. So the OCD workbook, The Imp of the Mind is an oldie but goodie, as well as The Doubting Disease, and some workbooks, including Overcoming Harm OCD and Overcoming Unwanted Intrusive Thoughts are also some resources for people who are looking for treatment for themselves or for a loved one. And that's it. Does anyone have any questions? Okay, if you do have questions at any point, you can reach out to me here at Butler Hospital or through email, mmancebo@butler.org. Again, it's just general questions about this presentation. But it was nice to share this information with you all tonight.